This is similar legislation to what's come before this body before. We had an iteration in 2015 that addressed the first version of right to try. We had an iteration come to this chamber in 2018 that expanded further to certain types of stem cell treatments. This is a modernization of the right to try that addresses individualized genomic and genetic treatments that are becoming more and more prevalent in modern medication. What it does allows patients under certain circumstances when they're terminal, there's no other options and courses, and there are no other treatments after they've exhausted all options to go seek individualized genetic treatments for their specific disease or condition. I'm aware of no opposition. We have talked to the academic medical research centers about it. We have discussed this with some various people in industry. Some patient right groups are very excited about this legislation. I think it's a nice dovetail as to what we have in current law, and will let North Carolina continue to be a leader in healthcare and healthcare sciences. I'm glad to answer any questions.
Thank you, Senator Sari. Do we have questions from the committee? Senator Robinson.
Thank you, Madam Chair, and thank you, Senator Sari, because, of course, I'm the biggest advocate for medical care, and having worked with sickle cell, I understand the importance of stem cells and all of those other things. But the question I have for you is, how does this differ from the patient's right to request or get access to any medical treatment? And secondly, does this bill mean that insurance companies will support that treatment?
Senator Sari.
Thank you for your question, Senator Robinson. There's no mandate to pay. There's no mandate generally for Medicare, Medicaid, or insurance companies to pay for a treatment that has not been authorized by the FDA. And probably, just to be clear on that, these are treatments that are still in research and experimental phases. So they have not gone through some of the necessary trials. There's an example of a medication to treat a rare brain disorder that's been approved in Europe since 2020. Patients are currently leaving the United States to go to Europe to receive that genetic treatment and then coming back here. What this bill would potentially allow them to do is to receive that medication in the United States before the FDA approval process is going forward. Excuse me. Is focused on individualized genetic treatments, which is the expansion of the current right to try bill, where it is for investigational drugs, a general category and classification of medications.
Okay, just a follow-up, Madam
Follow-up.
Chair. So it really falls in line with clinical trials or either advanced treatment in other countries that may not be available here. Is that what you're...
Senator Sari.
Thank you, Madam Chair. Potentially, that's certainly one broad category of likely choices if the European trial is advanced. And keep in mind that oftentimes FDA trials require hundreds, if not thousands, of different patients to show outcomes and process, years-long process. These are treatments that are uniquely tailored to one person or to one very distinct group of people. So the process that's currently in place is more difficult and more arduous than what we see with general investigational drugs.
Senator Mayfield.
Thank you, Madam Chair. So I think I understand why we need this. We need this bill because right now physicians either can't or won't engage in this, and medical facilities can't or won't for liability and other reasons, and maybe it's not, again, sort of authorized by DHHS. So we're just basically saying, even though these treatments are not approved, legal, all of that here, we're still saying we can do it. Patients can do it. Is that right?
Senator Sari.
Thank you, Madam Chair. Generally, that's correct. I mean, there's a very rigid process you have to go through. I mean, you can't walk in with a general, rare condition and say, doctor, I want drug 1, 2, 3. I mean, you have to have exhausted all options. You have to have given very rigid informed consent. You have to go to a very certain type of facility to receive it. It's not an easy process to get through necessarily. It's very controlled, but at the same time, it opens up options to patients for these specific individualized genetic treatments, which are going to become the medications of the future. I think that's where medical research is going in 2024 and going forward, is that we're seeing more genetic therapies that are targeted to treat these rare diseases.
Senator Corbin.
Thank you, Madam Chair. I have spoken to some of our insurance companies. It was mentioned a moment ago about the insurance. So there's no mandate in this bill, I understand, Senator Sari, for insurance to cover it. That is correct.
Yes, that is correct, Mr. Chairman, or Senator Corbin. There's no mandate to do it. Of course, if they just so choose to pay for it, they can.
Becky.
Thank you, Senator Sorry.
So these are non-FDA follow-up?
Follow-up.
Non-FDA approved treatments. Madam Chair, at the appropriate time, I would make a motion for favorable report.
Thank you. Any other questions from committee members? Anyone from the audience who'd like to speak? Seeing none, we have a motion from Senator Corbin. The motion, tell me if this is correct, favorable with a referral to judiciary, if favorable, a re-referral to appropriations-based budget, and if favorable, a re-referral to rules and operations of the Senate. Is that your motion?
That's exactly what I said. Thank you.
Thank you. All those in favor, please say aye. Aye. Any opposed? Thank you, Senator Sorry.
Madam Chair.
And our next bill is Senate Bill 681. And I want to let you know that the PCS, which was discussed last week in this committee, has been withdrawn from consideration. And the new PCS was sent out to all the committee members in accordance with the Senate rules and without objection is properly before the committee. Senator Reeder.
I don't think you wanted to promote me to center, but I appreciate being here.
I mean, Representative Reeder.
So
You are recognized.
Thank you very much, Madam Chair. I'm here without my sidekick. Representative Baker's daughter is graduating law school, so she is up in Boston. So I'm here all by myself, so be gentle. I'm here to speak on the original bill, which was 681, which really allows for interstate compact so that we can get medical licenses more easily across state lines. Nothing has changed in that I could see. The thing that I would just want to reiterate is that this helps with access for medical care, access for our patients, for physicians in the state. When other states have signed on to this, they see anywhere a 10 to 20% increase in the number of licenses in the state. The Medical Board of North Carolina still retains the authority to grant a license, and physicians don't have to go through the compact in order to get a license in North Carolina. So this passed in the House unanimously. I'm not sure if that helps or hurts over here, but we couldn't really find any opposition to the original bill. So I appreciate and hear for any questions that you might have.
Thank you, Representative Dr. Reeder. Senator Britt.
I just want to clarify something. This is a new PCS. So is this discussion only? Are we moving for it for discussion only?
No,
is this a new PCS
we will be
intend to
voting on
vote?
this one. We do
Okay.
intend to vote.
Okay.
Any other questions for this portion of the bill for Dr. Reeder, Representative Reeder? Seeing none, we have Senator Bergen to explain the remainder of the bill. Thank you, Dr. Reeder.
Thank you, Madam Chairman. It's good to see everybody here. Since last week, I've worked with stakeholders and members to incorporate some concerns that were raised in our committee conversation. You will notice some portions of the last PCS removed and other portions added. As before you, the proposed committee substitute to House Bill 681 establishes North Carolina as a member of the Interstate Medical License Compact, allows nurse practitioners to work without the supervision of a physician, requires anesthesiologists to be present at certain parts of procedures in order to obtain insurance reimbursement as consistent with federal TEFRA laws. This language has been previously considered in past sessions, addresses compliance with the currently required standard of supervision as detailed last week by Representative Baker, and for practices such as that anesthesiologists must be present for the beginning and end of any procedure. Requires all procedures performed at in-network healthcare facilities to notify patients if there will be any out-of-network charges, and prohibits most non-hospital healthcare facilities from charging facility fees and prohibits hospitals from charging facility fees for identified procedures. A remote location of a hospital. A remote location of a hospital is defined as a hospital-based facility that is created by a hospital for the purpose of furnishing services under the name, ownership, and financial and administrative control of the hospital. And this does not include any healthcare organization or facility that was acquired or purchased by a hospital. Madam Chairman, I'll be happy to answer any questions.
Thank you, Senator Bergen. Senator Adcock, you're recognized.
Thank you, Madam Chair, and thank you, Senator Bergen, for continuing to work on perfecting this PCS. I want to speak to the parts of the bill that begin on page 13. I think I can speak with authority about this part of the bill about nurse practitioners. I just wanted to point out a few things to kind of level set us as we start this conversation. And the first is that the language in this PCS will do nothing to change what nurse practitioners do every day right now, what they're educated, certified, and are doing. It doesn't change the scope of practice. It simply says for those first 2 years of practice, you will work with a collaborating provider to get those 4,000 hours of supervision, and after that, you have independent authority for your practice. This would bring North Carolina into the mainstream of regulation of advanced practice nurses. Over half the country regulates nurse practitioners in this fashion, so we would be joining the vast majority of the states. I would also point out that I think it's important for everyone to know that collaboration between nurse practitioners and other providers, particularly physicians, will continue to happen just as it does now. Nothing in this bill changes that, but also doesn't change the fact that that's a necessary component of care for everyone. We all practice interdependently, so that collaboration will continue. And as a corollary to that the conversations and the comments that have been made in the past about team-based practice, which are very valid, is that a team is whoever helps to take care of a patient, whether they're physically located together or away from each other. Whoever's needed to take care of a patient is a team, and there's no requirement that one person always be the head of that team. It's kind of a revolving responsibility based on the patient's condition, the patient's needs, who has the expertise at the time. So I'm hopeful that as we continue to discuss this part of the bill, that that contextual information will be helpful to everyone. And I thank you very much.
Thank you, Senator Adcock. Any other questions or comments from the committee? Senator Batch.
Thank you, Madam Chair. So I appreciate Senator Adcock giving that background information, because we are familiar with collaborative work in a lot of the healthcare space, including with physician assistants and whatnot. I have a couple of questions, Senator Bergen, and if staff needs to answer that, by all means, I'm comfortable with that. So may I ask a series of questions, Madam Chair?
You are recognized for a series of questions.
Thank you so much. So on page 14, it actually talks about a collaborating provider. And it says it describes what's needed for nurses to practice without physician supervision, or what they're calling a collaborating provider. What's the definition of a collaborating provider?
Senator Bergen.
My understanding as not being a physician is a collaborating provider is someone that, like, for example, in a hospital environment, where there is someone there that collaborates with nurse practitioner, advanced nurse practitioner, any of the different folks that on a case or care. And then I'll also, if I may, let you recognize Senator Adcock to add to that.
Also, I do want you to know there is a definition of collaborator in the bill. Would you like staff to read it?
That would be great. Thank you.
Jason Moran Bates, you're recognized.
Jason Moran Bates, Legislative Analysis. The definition for collaborating provider is on page 16, lines 3 through 7. It's a physician licensed under this article, Article 1 in Chapter 90, with at least 8,000 hours of practice experience, or a nurse practitioner licensed under Article 9A of Chapter 90 with at least 8,000 hours of practice experience. Collaborating providers must be in good standing with their licensing boards and not have received any professional discipline in the preceding 5 years.
Thank you.
Thank you, Jason. Senator Adcock, would you like to add something?
If I could, that would be helpful. So when we passed Senate Bill 20 last year, there's a part at the end of that bill about certified nurse midwives. And this language is consistent with the language in that bill, where a certified nurse midwife in that first 4,000 hours of practice can have either a physician who provides obstetrical care or a midwife with that 8,000 hours of practice. So this is consistent with that language.
Badge.
Thank you. So a nurse coming out who needs to be supervised for the amount of time that's in this bill be able to be supervised by either another nurse practitioner or a doctor. It does not require any supervision at any given point in time by a doctor. Is that accurate?
It gives the option to choose. Thank you very much, Madam Chair. Yes, it gives the option.
And another question.
You're recognized.
Thank you. So there's a definition. So we talked about collaborating provider. It also talks about practice experience. Mr. Bates, I don't know if there's a definition of practice experience, but if there is, I'd love for you to read it. If not, I would like for someone to explain what the practice experience is. And in context, does that mean that a doctor who goes through medical school and then goes through residency and then subsequently maybe a specialization, all of those hours are considered practice, just like a nurse who goes through practicums when they're in school? Or is it hours after they are fully licensed, get through everything that they're doing, and then subsequently move forward to have the definition of what is called practice experience?
We'll recognize Jason Moran Bates to answer that.
Thank you.
Jason Moran Bates, Legislative Analysis. Senator Batch, there is not an actual definition of practice experience anywhere in the bill.
Follow up.
Senator Batch, I believe Senator Adcock wants to add. Senator Adcock.
Thanks for the question. That's a really good question. Actually, it's 4,000 hours after you have completed, you've graduated, you've been certified, and you've started working. That's when the practice hours clock begins. And that's that again, consistent with the midwifery language in Senate Bill 20.
Senator Batch.
And if I could just briefly speak to the bill. So I really appreciate, and Senator Bergen, you listening to and always taking feedback from the providers, and being open to additions in this bill is definitely improved from the last version with regards to guardrails and other things that are put in place. I guess my issue is that in moving forward, and it doesn't matter what profession, we have many professions that still collaborate. So physician assistants still like the model in which they practice with doctors, and they like that care model. We have in many areas in this in our state, we have vet techs and veterinarians. We have paralegals and we have attorneys. We also have dental hygienists and dentists. In all of those three categories that I just gave, there are individuals that do get certified, have to go through additional training, but are not able to then practice at the level in which we are talking about in this bill. And I think that there's various reasons for that. I appreciate the additional time and having a ramp and no disciplinary action with regards to nurses, nurse anesthetists, et cetera. My bigger concern is that as an attorney who had an all-day trial on Monday, my paralegals helped me prepare for the trial, but there's no universe in which they would have been able to actually represent my client effectively in that court hearing, despite the fact that many of them have been a paralegal for years and years and years. And I think that we just need to be very thoughtful and careful of what we're doing when we move down a path in which other individuals have a lot of expressed knowledge and experience in areas that they've gone to school and they have more experience. They have higher liability insurance, right? Malpractice insurance. Paralegals don't cover malpractice insurance. They don't have malpractice insurance. Why? Because they can't practice independently. There have been conversations about paralegals going into courts and representing individuals. I would say that that's probably not, I would actually tell you that that would be extremely dangerous and wrought with a lot of issues. And I think that we, when we're talking about this bill, just need to be very thoughtful about what we are doing and making sure that the actual patients are being cared for. And since insurance companies were invoked in Senator Sari's bill, what I will also say is that one of my concerns is that pre-authorization, if this moves forward, is in a situation in which people may not be able to go to a doctor and have to go to someone else prior to actually getting pre-authorized to see a doctor. I've had very many complex medical issues throughout my life, including with regards to anesthesia when I have had my surgeries and I need a anesthesiologist there. And I think that it's really important for us to just, while we're going through and trying to figure out how to increase access to care and make sure that people are being provided for, that we're doing it in a way that is very patient-centered and very patient-focused without actually causing any additional harm. Thank you.
Thank you, Senator Batch. Any further questions or comments from the committee? Senator Woodard.
Thank you, Madam Chair. And I just want to thank Senator Bergen for his work on this. and while I continue to have concerns with the bill, I appreciate his openness and willingness to continue to engage us in conversation as late as 5:30 last night. So I'm grateful for that. And I do want to acknowledge Jason Moran Bates, another careful and thoughtful person who I suspect has put in a lot of hours on this over the weekend and yesterday as well, because drafting this can be tough. I think we all agree the compact piece, Section 1, is something we would all favor and move forward with. I still continue to have concerns about some of these things. Senator Bergen, you listened to some of the concerns I think we raised last week, but I still think we're coming up short in a few areas. Senator Batch, I think, did a good job talking a little bit about some of the advanced practice stuff. I still don't think we're quite there on the facilities fees. These continue to give me some concern, particularly in our rural areas, and being able to stand these up. In the dental practice, I'm not quite sure we're there yet when we have freestanding and ambulatory surgery centers are an important part of this as well. And my screen seems to be hung, so I couldn't look at the bill. So I continue to have a lot of concerns about where we are, and I hope we can continue. I know this has some other stops along the way. I wish we could move the compact piece ahead and continue to talk about it, because the issues, Senator Bergen, you brought to us are issues we've talked about for over a decade around here. Senator Kravick is nodding, and I think you and I will be leaving this place in a few months, but I suspect our colleagues will continue to be talking about it. We won't be here to do that, and we've had many conversations in this committee and on the floor and one-on-one about this. But I just, as I've often said, I feel like this cake's not quite baked yet. So we're not quite ready to start slicing it up and serving it. And I appreciate all the effort. I hope we can have more dialogue, but in this format, it's not anything that I think I can support without some more work and some more discussion. So I'll just leave it there. Thank you.
Thank you, Senator
Madam
Woodard.
Chair.
Senator Bergen.
Senator, I was going to name this after you in honor of you, but I decided not to this section. But let me talk a moment about facility fees. And I talked to a lot of folks, talked to hospitals, and something that's always concerned me as a business person was, and part of what we changed in this was because of a number of hospitals that don't have any room around their hospital, and so they add on clinics or facilities, and I wanted to make sure that those that they develop themselves could charge facility fees. But there just seems, business-wise, if someone goes and buys a standing doctor's practice, it's not affiliated at the time with their hospital or not even on the grounds or anything, and then they immediately can start charging 30 to 40% more as a facility fee for being able to do that has been a concern to me. And as we all talk about healthcare cost and the increase in healthcare cost, I've been looking for ways that we can draw attention to some of these things and some of the inequities, because somebody has to pay that bill. You're either paying it through, your personal finances or buying insurance, and then the insurance company pays it. And if their premiums go up, if their costs go up, then your premiums go up. And so it just becomes that kind of cycle where we're raising the cost of everyone. And I'll say it again, medical debt greatly concerns me. I've talked to numerous people in the last 2 weeks and talking about this bill that are dealing with significant medical debt that has impacted their credit to the point that it's just become overwhelming. So I've been here 6 years now, and we started talking about these things 6 years ago. My mentor and I have talked a lot about these from day one. So we're trying to move the ball on these. I don't want somebody that comes after all of us to be dealing with the same things. So I hope everybody will keep talking and keep trying to move these things forward.
Thank you, Senator Bergen. Any further comments from the committee? Senator Sorry, you're recognized.
Thank you, Madam Chair. I have some questions about Part 3, with respect to the TEFRA compliance for staff. May I ask a series of questions?
You're recognized for a series of questions.
Thank you. This has changed from the last PCS that I saw, and it came out late last night. I think I'm trying to understand what it is. Can you generally tell me, are there additional barriers or burdens that are being put on anesthesiologists or nurse anesthetists beyond what is already required under federal law within Part 3? And if so, could you describe or identify those?
Jason Moran Bates, you're recognized.
Jason Moran Bates, Legislative Analysis. Senator Sari, the Part 3 of the bill largely follows federal law. Under federal law, there are certain things that an anesthesiologist has to do in order to bill as providing medical direction to Medicare. Part 3 of the bill just copies those requirements from federal law and extends them to state things like the state health plan, Medicaid, and state health insurance, or insurance under Chapter 58.
Senator Sari.
Thank you. Another question. So just to understand, so TEFRA compliance is not currently required for anesthesiologists and CRNAs under state health plan and Chapter 58 health insurance companies in North Carolina. Is that correct?
Jason Moran Bates.
Yes, that is correct.
Follow-up.
Follow-up.
Can you describe or illustrate to me, I guess, the exact changes this would make in their scope of practice and how they operate under those different circumstances?
Jason Moran Bates.
Senator Sari, I don't know that it necessarily makes any changes to the scope of practice. What it does is it makes changes as to how they have to do things in order to receive insurance payments. If you look at page 17, page 18, we're starting on lines 23 through line 36. There are seven separate items there. In order to receive the payment from an insurer, the anesthesiologist would have to do all of those things: perform a pre-anesthetic exam, prescribe an anesthesia plan, participate in the demanding parts of the procedures, ensure that procedures put forth in the anesthesia plan are followed, monitor the course of anesthesia, remain physically present for diagnosis and treatment of emergencies, and provide indicated post-anesthesia care. As I said earlier, those are the elements that are under TEFRA. So an anesthesiologist that wants to bill for giving medical direction to Medicare would also have to do those things. This bill would just extend that to insurers in North Carolina.
Senator Sari.
Thank you, Madam Chair. And I'm going to admit that I've not read TEFRA verbatim, but as somebody who's read statutes any number of times, looking at this, words like some portion and demanding procedure, I mean, that gives me pause. Is this verbatim from federal law?
Jason.
Senator Sari, I don't know if it is verbatim from federal law. I believe it is, if not verbatim, very, very close. If you give me a couple of seconds, I can look it up and probably find the answer for you.
Okay.
Senator Sari.
I would just comment, and this is just statutory reading, that some of this is ambiguous, describing what part is some portion, how's that certification going to happen, demanding, et cetera, so on and so forth. I'll continue to read it. But again, it's a new PCS, so I appreciate the opportunity for the questions.
Madam Chairman.
Thank you, Senator Sari. Senator Bergen.
Senator, one of the things that I've been meeting with additional groups, every day and even early this morning, and I'm also still looking at the TEFRA language to make sure, and I'm trying to see financially that there's no impact on any of the other folks, but it is federal law. So, I mean, the feds thought it was some significance in doing it. It's come up numerous times in conversations as the reason that we added it in here, but I'm continuing to look at that. Thank you, though.
Thank you, Senator Bergen. Senator Mayfield.
Thank you, Madam Chair. Just since we're on this topic, I want to point out that this may be required by federal law and by insurance companies and through this bill and in North Carolina law, but I was with about 20 CNRA students yesterday, and they're two professors, and those professors are also practitioners, in different hospitals in Western North Carolina. And I asked them about this because Representative Baker had mentioned, this in our meeting last week, particularly about anesthesiologists being present for induction and emergence. And I said, does that actually happen? And there was laughter around the table. They said, no, that does not happen. That does not happen every single time, every single surgery. There's absolutely not an anesthesiologist present in the room during every emergence and every induction. And one of the instructors said, if you required that, you would bring the whole system to a halt. So I don't know the answer to that because we can't change federal law. I just want to point out that there may be a difference between what is the words on the page and the way the system actually works. And, I'm not suggesting that we pass something that is not consistent with federal law. That would not be a smart thing to do. But in these conversations, I think we should all be aware of what we think happens and what actually happens. Because what actually happens, at least in this case, is not what everybody seems to think is supposed to happen.
Thank you, Senator Mayfield. Senator Batch.
Thank you. I just have another question for staff, please.
You're recognized.
Thank you. So on page 17, line 18, it appears to change the CRNA from definition from supervision instead of collaboration. Does that mean that there are no requirements for supervision moving forward and it allows for CRNAs to actually practice independently?
Jason Moran Bates.
Jason Moran Bates, Legislative Analysis. So this does not change those requirements. I believe we said 17 line 18, it's just talking about performs nurse anesthesia activities in collaboration with the physician, dentist, podiatrist. It's just defining what is a certified nurse or a certified registered nurse anesthetist. It doesn't actually change anything in the requirements for them. This is just the definition. If there are requirements for supervision elsewhere in statute, those would still hold. This doesn't change that.
Senator Batch.
Follow up, and you may not know this. So since it's always said supervision, do you know why it was changed to collaboration then in this instance?
Jason Moran Bates.
Unfortunately, I do not know that.
Follow up. Senator Bergen, do you know why it was changed to collaboration rather than supervision?
I know that we had numerous discussions about medical supervision, collaboration, and all of that. And again, I talked to a number of the nursing organizations, different groups. Again, I know we have someone here that meets these requirements. If you would mind calling on her again.
Absolutely. Senator Adcock.
Thank you. I appreciate the question. Thank you, Madam Chair, and thank you, Senator Bergen. So this is actually the current language. They work in collaboration with the supervision piece, I think, that you're referring to, Senator Batch, is that supervision is only about reimbursement under Medicare Part A. There's never been supervision, a statutory requirement for supervision of the practice of CRNAs in our state. So this language, this collaboration with this current statutory language, nothing has changed about their scope of practice. They're not required to be supervised for practice, only under that supervision piece is about to bill for under Medicare Part A.
Senator Batch.
Just follow up.
Follow up.
So the supervision piece requires for an anesthesiologist to be in the hospital. They can't be remote on the phone or via Zoom.
Senator Adcock.
Well, the 7 articles of participation, those TEFRA 7 points, says they're supposed to be in the room, they're supposed to be participative, and I think it's been discussed by this committee, and I think Senator Mayfield put this very nicely, what is supposed to happen on paper and what's actually happening. There's a gap in there, and so I think that's the answer to your question.
Senator Batch.
Just a follow, just a comment. And I agree, there are a lot of things that happen in practice that should not, because we are violating probably some policies and we need to clean that practice up. My greater concern, and again, I brought this up last week, is that I am very concerned about patient care outcomes and malpractice coverage. And when you can harm an individual, and we may not have individuals who are practicing independently who decide to have a higher level of malpractice insurance, the family is harmed, that individual is harmed, and I don't think that we should change laws simply because we aren't doing things the right way. I think we should actually just demand in a area of especially such important situations like we're talking about people's physical health, that we demand that they actually follow the law and that they are implementing best practices per federal law, our state laws, et cetera.
Madam Chairman,
Senator Bergen, you're recognized.
I think we have some speakers. I met with some folks early this morning that I think that when the committee here, it gave me a different perspective about things. And so I think when we hear them, some of these may be answered.
Thank you, Senator Bergen. Yeah, I believe some of those questions may be answered by some of our experts. Any more questions? Senator Robinson.
Thank you, Madam Chair. Just one clarification, and I just want to add on to Senator Batch that, you know, our primary concern ought to be the quality of patient care. Just like we're concerned about costs to people, we ought to be concerned that they receive the best care, best quality of care by the most trained and certified people. So my question actually leads to, and maybe Dr. Rita can help us here, what's the difference in the malpractice insurance required for a provider, a doctor, as opposed to a nurse practitioner? Do we know what the malpractice is? And I see Jason looking up, so maybe he knows that.
Well,
Senator Bergen.
One of my businesses is insurance, and I've talked to numerous people about, and the insurance, of course, is based on risk and then prior acts. So you could have people that and I think we're going to have some people talk about what they pay for insurance in practice, but it can be from a few $1,000s to 20s and 30s of thousands of dollars, depending on what they're doing and their history of action. So, and Dr. Reeder, I'd be happy for him to speak to, and it depends on the level of insurance. You can carry multiple, you can carry $1 million liability, you can carry a $15 million liability. And there again, I think it's going to determine on what you're doing, your history. We've got people that I've talked to that have been in practice for 20 and 30 years, never had an incident. We've got other folks that I've looked at cases that they've not been so prudent about it. So
yeah, I would think that anesthesiology, the administration, is a higher level of risk. I don't know. Dr. Reeder, would you share? Please?
Dr. Reeder, you are recognized.
So admittedly, I'm not the expert on malpractice. It is a significant practice expense, and it is based on your experience, what you practice. If you practice neurosurgery or obstetrics, your malpractice rates are going to be much higher than if you do primary care. I can't speak so much to nurse practitioners who might be practicing outside of health systems. Most of them that are practicing in health systems, most of those health systems are self-insured. So there's not necessarily a specific line item, but I can't speak to what they're paying when they're working outside of health systems.
Senator Adcock, enlighten us.
Thank you, Madam Chair. So, Senator Robinson, I think you're really asking about what are the liability limits. So not what people are paying in premium, but what the limits of liability are, am I right? So that the patient is protected if they need to, right. And so what I would say is that those are the liability limits that physicians, nurse practitioners, PAs, whomever is practicing in the practice have usually is determined by the practice itself. And I'll use the example of the practice I ran at SAS. So our physicians, my 4 physicians on my staff and the 11 nurse practitioners on my staff, were all had the same limits of liability. Their policies were exactly the same as to what they were covered for per occurrence and in the aggregate. That was a decision we made as an organization and as a practice. So that's a decision every business makes. And if you're doing the same kind of work, probably the same kind of limits of liability are indicated. So I hope that's at least some answer to your question. And may I add one more thing? Oh, she's got a follow-up. Sorry.
No. So I think I hear you saying that then hospitals would insure or provide liability limits regardless of whether it's the anesthesiologist or the nurse practitioner? Is that what you're saying?
Senator Adcock.
Thank you. So actually, I wasn't speaking about anesthesiology. That's not my specialty. We have some speakers who are coming, I believe, who can do that. But what I would say is each organization decides what the liability limits for their providers should be. And I would also say that even though we had umbrella coverage, entity coverage for our practice, we also had individual liability policies for each of our providers. And that's kind of the standard out there, that people cover their own individual liability as well as the entity liability coverage. And I also need to correct something I said incorrectly earlier,
Okay.
if I might. So when I said there was no statutory requirement for CRNA supervision, I misspoke about one thing. There is one place in the statute, and that's in the dental rules, that when a CRNA is administering anesthesia in a dentist's office for surgery or whatever they're doing that requires anesthesia, that dentist right now in those rules says they supervise that CRNA. So I apologize for neglecting to state that, but there is no general umbrella universal supervision for CRNAs for anything other than that.
Thank you, Senator Adcock. Senator Bergen? Any other questions or comments from the committee? Senator Woodard?
Thank you, Madam Chair. I guess just a thought on this. There was a famous movie in the 1950s it was a Japanese movie. It has subtitles Brit, so you probably wouldn't want to watch it, but it was called Rashomon. Kurosawa was the great director, and it was the story of a murder of a man coming through a town, and it ends up being told by 4 different people, and they all had a different perspective on the murder, and they all had some role in the murder. And it influenced film a great deal. It's Arts Day, so y'all forgive me for being a little arty here today. But reading this bill and listening to this conversation today made me think a lot about Rashomon, because we're all having different perspectives on this. And I think it proves an argument I've made in this committee and with some of you all for some time, is that we need to all get some folks in a room, not pick one person. Senator Bergen, thank you for being that person to run point on this, but to come with all the perspectives that we've got, to bring all of these stakeholders in here and keep hammering through this. Because a lot of the questions and conversations that we've had in here today are helpful. They're good to hear. But Senator Kravick, you and I have heard some of these for over a decade now. And if we're ever going to accomplish anything and not just keep having the same argument and the same discussion each year with a different bill, call it the SAVE Act, call it whatever you want to call it, and putting it in pieces of legislation, it just, when are we going to grab the bull by the horns and take on some of these issues and not try to put them in a short session, not try to amend it to a good piece of legislation that we need to move forward with the compacts. And I don't want to call this a troubled piece of legislation. It's just something that needs a lot more conversation. And Senator Bergen, I'm grateful that you're open to having the conversation. But how many conversations have you had on this in the last 48 hours? I bet dozens of conversations. And it's just time for everybody who has a stake in this to get in the room and let's just hammer this thing out. I don't know that we've got time to do that in the short session. Healthcare lobbyist reminded me last night, we did this back in 2014. I remember Senator Tart, me, Representative Avila, Representative Sarah Stevens, we all worked on some maternal health legislation, and we sat for months and worked on it. We didn't get a perfect bill, but we came out with a good bill because we were willing to sit in there, roll up our sleeves, and work through this. And on a lot of these scope issues and the concerns about cost and things that Senator Bergen rightly raises anytime you ask him about it, it is time to roll up our sleeves and just get this stuff hammered out, so we don't keep having 4 different stories or multiple stories about trying to cram it all into one bill. So I'm sorry, I need
Thank
to
you,
say
Senator.
that.
Thank you, Senator Woodard. Senator Bergen?
And Senator Woodard, I agree with you, but what I've learned up here is sometimes if you don't start moving things ahead, people just want to just sit and not. And if this was the first time that we had discussed a lot of these issues, it would be one thing. But 6 years of talking about things. If this was a business, it would not be very successful because the decisions are hard to get made, and there's a purpose for that. And the purpose is to make legislation better. And I've tried to do that, and I've said, and I'll say it again, I am willing to talk to anyone about anything that makes this bill better, but I do want to try to keep it moving so that people will continue to talk.
Thank you, Senator Bergen. And we very quickly, because we've got some speakers.
Got it, yes. Because the concern I have, Senator Bergen, is that this conversation, you appended onto a bill that has unanimous support. So by adding sections 2 and following, we've gummed up a piece of legislation that we do need to move forward. Senator Reeder and they promoted again, Representative Reeder and Baker's hard work on that. So anyway, I understand it was a provocative move on your part, but sadly you've linked two things. So anyway.
Thank you, Senator Woodard. And we have speakers in the audience that we definitely want to hear from, but the chair wants to make a couple of comments. I just want to point out one thing. We have a number, a number of hospitals in North Carolina who have no anesthesiologist. I don't know how many of you know that, and I don't know how many, but there are a number that have no anesthesiologists. So I just want to remind you of that. There are no safety issues. The data is overwhelming that there is no safety issue, and we're not the first team on the court. It's in many states. 40 states have some on the anesthesiologist, but we're not the first one to the game, so we have learned from what other states have done, and there's no safety issue. We don't really even hear that anymore because the data does not support it. So I just wanted to make you aware of that. And patient safety is paramount, so we wouldn't be talking about something if a safety issue was involved. And Senator Woodard, you were talking about time to take the bull by the horns. Well, like you said, we've been talking about it, for 11 years. So I think it's time to stop talking and start doing something, as Senator Bergen said. There comes a time when talking has been done enough. And yes, everyone should get to the table and put their input in, and Senator Bergen's willing to do that. But we have some that aren't willing to come to the table. We've been trying that for 11 years to get everyone to the table, and some will not participate. So it's time for us to move forward and to at least get this conversation going, to try to get a good bill. And I don't know if some of our speakers will talk about Dr. Conover's study from Duke. He updated it recently, and he estimated that North Carolina would save, I think, between $900 million and $6 billion if we pass some of these provisions. Someone said to me yesterday, well, I don't believe that. I might believe the $900 million. I said, I'll take that. Can you imagine how much health care we could provide in some of these underserved communities for $900 million, let alone the billions? But those are legitimate estimates. So that's just my take. Now we're going to recognize some speakers that have signed up to speak. And first we have Crystal Tillman, who is the CEO of North Carolina Board of Nursing. And Sergeant at Arms, we will give each speaker 2 minutes.
Thank you, Madam Chair. Good morning, and thank you for the opportunity to address the Senate Health Committee today. My name's Crystal Tillman. I am a dual certified nurse practitioner in pediatrics and psych mental health, and the Chief Executive Officer at the North Carolina Board of Nursing. The mission of the Board of Nursing is to protect the public by regulating the practice of nursing. The remarks I provide today are based on the lens of public protection. The Board of Nursing supports the option for full practice authority for nurse practitioners. The national standards have proven safe and effective and appropriately safeguarding the public. They serve the public by increasing access to care, especially rural communities, without compromising patient safety. This approach is either already in place or is being implemented throughout the country to ensure that all NPs can practice to their full scope based on their education, licensure, and certification. Importantly, no state has aligned with this regulatory approach, has ever reversed its course. And I would like to point out that in doing so with the regulation, if a nurse practitioner would go beyond the scope of the practice, the Board of Nursing will certainly investigate the nurse practitioner and certainly disciplinary actions by the Board of Nursing. The Board of Nursing operational structures is highly effective and has sufficient human resources, infrastructures, and technology for licensing, reviewing credentials, providing consultative services regarding APR in practice, investigation, monitoring, and prosecuting cases. For the past 5 years, the Board of Nursing has investigated and resolved approximately 86% of all nurse practitioner cases. The medical board only investigates nurse practitioners when a physician and a nurse practitioner are reported together in a complaint. Stop. Thank you.
Thank you, Ms. Tillman. Next, we have Kimberly Gordon from the North Carolina Association of Nurses, Government Affairs Director. And after Kimberly, we have Elena Meadows, so I'll just have her get ready to go up next.
Thank you very much for the opportunity to speak with everybody, and thank you to the committee and senators for the opportunity to bring this issue up. My name is Kimberly Gordon. I'm a certified registered nurse anesthetist. I've been practicing for over 16 years. I am the North Carolina Association of Nurse Anesthetists Government Relations Director and a past president. And I currently work in Winston-Salem on an as-needed basis for Novant Health, meaning I fill staffing holes there. Unfortunately, there are many. I'd like to clarify a few misconceptions and to clarify some differences between what we're talking about. A lot of the terminology we're using is related to reimbursement and not practice. When we're talking about medical direction and TEFRA, that is so we can bill for the services that we're providing. That in no way reflects the practice of what's happening across North Carolina. In 137 facilities in our state, CRNAs are practicing independently. Medically directing CRNAs is one practice model, and it is the second most expensive practice model that we are using. The only more expensive model was if physician anesthesiologists were delivering anesthesia on their own, independently. Anesthesia care teams there are different models within anesthesia care teams. They're not all medically directed. Some are working with CRNAs and physician anesthesiologists, but there are other instances where CRNAs are working independently and other instances where physicians can work independently. So what we're talking about here is very different. We're conflating two very important issues. And I think that's collaboration. Oh, and I would like to, Senator Batch mentioned this. The administrative rules in North Carolina, the administrative code, that language in this PCS is pulled out of the administrative code. We have collaboration. We do not have supervision anywhere, but as Senator Adcock said, in the Dental Practice Act is the only place that CRNAs are supervised in North Carolina. Otherwise, we're working in collaboration, which means, of course, that we don't want to remove our physician colleagues, and we're not removing our physician colleagues from the practice of anesthesia, surgery, medicine.
Thank you, Ms. Gordon.
You.
Next, we have Elena Meadows, from North Carolina Association of Nurse Anesthetists. She is serving as their president. And after her, we have Bob Whitehurst, if he would get ready to speak.
Thank you, Senator Krogh. Thank you, Senator Bergen. Thank you to the committee for hearing my comments. As Senator Krogh said, I'm currently the president of the North Carolina Association of Nurse Anesthetists. I also work full-time as the didactic director in the Wake Forest Nurse Anesthesia Program. We have 6 outstanding nurse anesthesia training programs here in North Carolina. We attract the best and brightest from across this state and many other states to come here and train in this very rigorous program where they learn how to deliver anesthesia. What happens, unfortunately, because of so many restrictions and difficulties in many practice environments in North Carolina, we have a lot of attrition. We lose a lot of our graduates to other states, as you mentioned, Senator Krog, that have much more favorable practice environments. As a matter of fact, our 2023 class last year that we graduated 24 new nurse anesthetists, and only 4 of them remained in North Carolina because of more attractive practice environments in other states. That's largely the reason that they cite. And we also just want to say that these young learners come here and they suspend their careers as nurses, as ICU nurses for 3 years. They are involved in thousands of hours of education and training. They do thousands of hours of anesthetic care in these programs. They are all independently licensed nurses, and they are board certified through our national certification organization. So again, this is a problem that we're losing our learners to these other states. So I would also like to say that anesthesia overall is very safe in the hands of a properly educated, properly trained provider. It is one of the safest medical procedures that you can have. And our insurance malpractice rates reflect that. I do independent practice. I collaborate with a non-anesthesiologist physician, and I pay about $90 a month for malpractice insurance for that. So again, it's very safe in the properly trained, properly educated hands, regardless of the provider's degree. Thank you so much for your time.
Thank you, Ms. Meadows. Next, we have Bob Whitehurst, owner of Advanced Anesthesia Solutions. And following Bob, we have Alex Miller, lobbyist for the North Carolina Nurses Association. You're recognized, Mr. Whitehurst.
Thank you, Senator Crawford. Thank you to the committee for having this hearing today and for allowing me to speak at this hearing. So yes, my name is Robert Whitehurst. I am from Eastern North Carolina. I'm a certified registered nurse anesthetist. I attended East Carolina University for my undergraduate nursing degree. I attended Duke University School of Nursing for my anesthesia training. And I have been a certified registered nurse anesthetist for 20 years. I also served in the military. I was with the United States Army Reserve. I served in Iraq in 2006 in support of Operation Iraqi Freedom. I was one of 2 anesthesia providers on a base of 6,000 people. Both were CRNAs, no physician anesthesiologist. We treated gunshot wounds, IED wounds, very, very massive injuries. People with half their face blown off, body parts missing, and we were CRNAs, and we were there to do that. Again, without any direction or involvement from a physician anesthesiologist. My company, I started a company in 2005 called Advanced Anesthesia Solutions, thank you, sir, to provide anesthesia care to outpatient facilities. We provide 30,000 cases per year in outpatient facilities to all kinds of, all different varieties of practices, GYN, endoscopy, plastic surgery, dental, a lot of different kinds of practices. We provide moderate anesthesia care, or what you might know as sedation. We also provide general anesthesia with ET tubes with patients fully asleep, none of which involves any anesthesiologist supervision or involvement. And going on the safety, my malpractice insurance for my personal policy and for my company is less than $6,000 per year. So CNA knows how safe my care is and how safe the care that the people who work with me, all CRNAs, certified registered nurse anesthetists, provide. Thank you.
Thank you, sir. Next, we have Alex Miller from the North Carolina Nurses Association. You are recognized, Mr. Miller.
Thank you so much, Madam Chair, members of the committee, for the opportunity to speak. My name is Alex Miller. I am a lobbyist for the North Carolina Nurses Association. Like Bob, I'm also a veteran, served in the United States Infantry, was injured in the line of duty, medically discharged. I received excellent health care during my time on active duty. I received excellent health care at the VA hospitals and clinics here in North Carolina. The nurse practitioners that care for me, servicemen and women across this state, on Lejeune, Bragg, Cherry Point, at VA hospitals and clinics across the state, do not have a physician supervision requirement that they practice under. They do practice collaboratively. As Senator Adcock pointed out, no provider of any kind practices alone. If they were to do so, as Ms. Tillman pointed out, they would be subject to discipline and loss of license by their appropriate oversight board, because that is not the standard of care. It's not the standard of care on any military base in North Carolina. It's not the standard of care on any VA hospital or clinic in North Carolina. It's not the standard of care in any of the 27 states that have already passed this bill. I appreciate that Senator Woodard brought up the bipartisan, bicameral study committee that he helped chair back in 2014. I was heavily involved in that as well. That was 10 years ago. As Senator Woodard suggested, we got everybody around the table, all the stakeholders involved, had great discussions. That subcommittee unanimously recommended essentially this provision at the time, 10 years ago. The larger Oversight Health Committee then unanimously recommended in legislation these same provisions 10 years ago. They have not passed. The Senate passed the SAVE Act last session. The General Assembly passed into law last year almost identical provisions to the ones in this bill for nurse practitioners as the ones that for certified nurse midwives. The requirements of physician supervision were suspended during COVID, these twice a year check-ins, suspended during COVID. No increase in incidents, no loss of patient safety. We've been talking about this issue for as long as I've been down here. We've been talking about this issue since this law was first passed 40 years ago. The rest of the country is moving on. The military does not do this, and patient safety does not suffer. But patient safety does suffer when people do not have access to care. We have 550,000 new North Carolinians covered under Medicaid. They have affordable health care. But if they can't see providers that are qualified to treat them, they don't have accessible health care. So these folks don't get care in your communities and show up in the ER with worse outcomes and higher costs for all of us, worse outcomes for them. We've been talking about this for a long time. We've passed this bill in fits and starts. I urge this committee to pass it again today.
Thank you, Mr. Miller. Senator Corbin is recognized.
Thank you, Madam Chair. I appreciate all the conversation we've had today, and it's been some good conversation. I will just say myself, and a lot of us here, Senator Barnes, different one, we represent rural North Carolina. And some of these issues are very important to rural North Carolina, access to care. We've talked about these things a lot. And I know there's some concerns moving forward. Let me point out this bill still needs to go to rules, needs to go to the floor, needs to go to the House through the committee process. So, Madam Chair, I'm going to make a motion for a favorable report for the PCS, unfavorable to the original with a referral to rules.
Thank you, Senator Corbin. You've heard the motion. All in favor, please say aye. Aye. Opposed? Thank you. Bill passes, and we are adjourned.